Hello, everyone. Continuing on with our investigations, today I wanted to talk about ICGs and FFAs. I'll do a bit of an introductory bit on what ICGs are and some indications, and we'll focus most of our discussion today on FFAs, their indications, the different sort of findings that you'll come across and how some pathologies may look. And I find in terms of general practice in your exams, the FFAs tend to be where the meat of the information that you need to know is from. So it's very much worth getting your head around how FFAs work and what they may look like. So we're going to talk about how an ICG is performed, the different phases and some indications. And then we'll go on to the FFAs, how they're performed, how to consent for them, the different phases of the FFA, which are definitely worth understanding, and then different patterns of hyper and hypofluorescence. So both ICG and FFAs are essentially angiographic tests. They're looking at the blood vessels around the eye, and they're looking at essentially the choroid and your retina. So indocyanine green is something that can actually be visualized through the retinal pigment epithelium, whereas your fluorescein can't. So with ICG, it's 98% protein bound. It doesn't leak into your choriocapillaris, and that all means that you can visualize the choroidal vasculature quite well. The difficulty with the fluorescein is that while you can't visualize choroid very well, it does give you a very good view of your retinal vessels. So it's 80% protein bound, it does leak into your choriocapillaris. And then these absorptions and peak emissions are about how, therefore, you're going to shine what light and what light you're going to get back. So how to perform an ICG, patients are going to get about 25 milligrams of indocyanine green. You may get lower doses depending on the machine that you've got. They get a 5 ml flush, and then pictures are taken over 45 to 60 minutes. And an ICG is typically a slightly longer examination compared to an FFA. And you have this early phase, which can be split up into 3 stages. So you've got this rapid filling of vessels within the first couple of seconds. Then the larger choroidal vessels are filled, and then you have up to 3 minutes of where your larger vessels start to fade. Your middle stage is up to 15 minutes, where all of the vessels are starting to fade. And then at 60 minutes, you're essentially looking for any staining outside of the choroid. And your indications are looking for things like vascular conditions, things like AMD, PCV, wrap lesions, specifically where you're worried that there are lesions or membranes that are coming through from the choroid. Inflammatory conditions, where you're worried about things like choroiditis, VKH, and certain malignancies as well, might be where you might consider doing an ICG angiography. So moving on to FFA, like I said, this is looking specifically at retinal vessels. It doesn't give you a good view of the choroid, but it gives you a very beautiful view of your retinal vasculature. And there's lots of different indications. So retinal vascular disease, diabetics, vein occlusions, CNVs, inflammatory conditions, very similar to sort of your white dot syndromes, posterior uveitis, and any sort of unexplained visual loss where you've not got anything on a clinical exam and you're wondering what might be happening on a vascular level at the retina. There are certain relative contraindications. So for those who are pregnant, patients who've had previous allergic reactions, and this whole thing about shellfish allergy is more relevant to ICG. It's not really relevant to FFA. So how do you perform it? They'll get 500 milligrams. This is for an adult dose. There are weight-dependent dosing for children. You get some early images every 1 to 2 seconds, and then you're going to be taking some images all the way up to about 30 minutes after they're injected with the FFA. Some of you may be involved with actually consenting your patients for an FFA in your medical retina exams. So the most common side effect of an FFA is actually just some nausea, some vomiting, generally feeling a bit unwell, maybe some fainting. Hypersensitivity reactions are quite rare, but they may actually develop a rash, in which case you might find that whenever somebody does have some FFA, they do have some oral antihistamines to hand. The risk of anaphylaxis and death is really quite rare. So anaphylaxis is something like 1 in 100,000, and death is like 1 in 250,000. So those are your sort of formal numbers, but it is exceptionally rare. But obviously, any patient who's shown allergy before is going to be contraindicated for an FFA. So with your FFA phases, these are going to be certain phases taken at certain seconds. So you start off with your choroidal phase, where you're going to get filling of the choroidal vasculature, but the FFA hasn't quite reached the retinal vasculature yet. So you can see the sort of white background, and the retinal vessels aren't yet filled. Your arterial phase is 1 to 2 seconds after that. It's usually very, very quick. You're not seeing any veins being filled at this point, but you can see the fluorescein pushing through your arteries, as you can see in this picture. Arteriovenous phases, I mean, some of the bosses I've worked with sort of describe this as more of an academic phase rather than a clinically kind of relevant one. But your venous phase starts with an early sort of phase to your venous. So what you can see here is that your arteries are completely filled with fluorescein. But if you can appreciate closely on this picture, so if I run my mouse here along this vein, you can see these sort of three lines, a bright white line, a dimmer line, and another bright white line. And that's because what you're having here is the fluorescein has got this laminar flow through the vessels, because your plasma runs through the middle. So what happens is actually what you'll see is the fluorescein are on the outsides of the vessels first in the early venous phase, before the veins are then completely filled in your peak venous. So this is the peak venous phase where essentially your vein is being filled just as much as your arteries. So when your arteries and your veins are essentially the same amount of brightness, you're looking at your peak venous. And then what happens after that is you then get the recirculation where everything then starts, the later things start to stain. So things like your optic nerve, your sclera, your Brooks, your choroid. But th those are the main phases that you need to worry about. So that first choroidal, the arterial, the early venous, and your peak venous. And now we'll start talking about the sort of pathologies that you're going to come across. So there's four different types of hyperfluorescence that you're going to see on any FFA. And the first one is leakage. So if you think about what leakage is, essentially you've got blood leaving the vessels. So this is going to progressively enlarge, and your borders are also going to be quite indistinct because essentially something gets leaking. And this is kind of what this looks like. So over the course of the FFA, you'll see these areas of brightness become more bright. They'll also become larger, and they have very sort of indistinct borders. And this is very typical of something like an NVD. Um, or for example, for something like this is a sort of your typical patelloid macular edema, and this is where you've got leakage happening at the back of the eye. Pooling is, again, as it suggests, pooling is pooling of FFA into an area that is predetermined. So it's going to progressively enlarge as that area is filled, but then it will be fixed in size after that. And this is quite typical of something like a PED. So it's essentially filling up that gap with fluorescein, but that gap is limited. So eventually it will then stop, have a distinct border, and stay that size for the remainder of the FFA. Staining is a sort of progressive brightening, but it stays the same. This is not something that describes, you're not going to see staining with something like a CNV, but you may see it with sort of ischemic vessels, for example, or you might stain at the optic disc. You may see some staining around drusen, where these things will progressively get more and more bright, but they stay the same size, which tells you that there's no leakage. And then finally, a window defect. And this is essentially where you can see the staining of the fluorescein from the choroid behind the retina, and that's why it's so much brighter. So what you can see here is you've got an early defect. This will come out very early because your choroid is what's going to get the fluorescein first. The fluorescein won't run by your retinal, won't run through your retinal vasculature. So where you've got an RPE defect, you'll see that early, and it will remain very static in its size and brightness because it's essentially just a defect of the RPE. So it's a window through to the choroid. And then you've got the patterns where you get hypofluorescence, so a reduction in the fluorescence, or something that's a bit darker. And what you'll see mainly is something like blocking, for example. So that's blocked by an opacity. Now, that while that is usually blood, it can be something like a nevus, it can be something like a melanoma, or for example, in Stargardt's, something like a lipofuscin, where you get this typically dark choroid. And that's a blocking defect. So there's fluorescence happening underneath, but you just can't see it because there's an opacity in front of it. And this is why an FFA by itself is limited, because you need to match that up with a clinical exam to see what the retina looks like, to see where that blocking is coming from. Is it blood, for example? And then you've got something like a filling defect. Now, a filling defect is essentially just fluorescein isn't reaching that area. So it's usually a blockage in a vessel, or for example, capillary non-perfusion in ischemic eye disease. And capillary non-perfusion is a really sometimes quite subtle sign to pick up on when you're looking at fluorescein. And if you've appreciated from all of these pictures, the general capillary bed of a retina does have this sort of light gray color to it. There is some fluorescein running through, as you can see in all of these pictures. And then in this last one, in this area of capillary non-perfusion, you can see along the sides of the vessels, you've got this dropout. And this tells you where you don't have any fluorescein coming through because you don't have any blood flow. And then you'll get this sort of almost feathering of the vessels alongside it. This is typically telling you that this is an ischemic eye. So when you're looking at something like a CRVO or a BRVO, these changes will make you slightly more concerned that the patient is more ischemic, they have a higher ischemic drive, they're more likely to get lots of VEGF being pushed through, so they're more likely to get complications of those retinal vein occlusions, like new vessels, for example. example, and rubeosis. So when you're interpreting the FFA, you want to consider what the indication was. Why did we do the FFA? Is this a patient who's inflammatory? Is this a patient, for example, who we have a poor view of the fundus and we want to know whether or not they are proliferative? Or is it somebody, for example, who has a CNV or someone for whom you need some further investigation to know exactly what's going on a vascular level? You're then at the time of the FFA, these are patients, whoever has an FFA will probably, they'll have an OCT on the same day. They should have some photographs as well because you want to be able to compare the FFA to the photograph. Now, sometimes a patient who's having an FFA, they're already going to have capabilities of taking a photograph on the same machine. So those photographs will be taken. You'll have a couple of wide field photos of the picture. So then you can, like I said, you can compare those areas of blocking, for example, with what's actually going on on a color photograph of that patient's retina. You want to obviously check the patient's detail. You want to see what date the investigation was taken. And then whenever you're looking at a picture, you want to look at the timing. You want to know whether or not this is an early picture or a late picture because it helps you understand whether or not this area of leakage is a very early leakage or a late leakage. So I wanted to just show some typical cases that you might come across. So how do we interpret an FFA? So looking at this first case, what you can see here is a patient's right eye. And what you can immediately say is that this is a fundus fluorescein angiography taken of a patient's right eye centered on the disc and macula. And before you go into it, you want to describe what phase this in. So as we said beforehand, what you can see here is full filling of the arteries, but you've got this laminar flow of the veins. So this is a fundus fluorescein angiography of a patient's right eye centered on the macula and disc. And this is a picture taken in the early venous phase, as shown by your trilaminar flow of the veins. And then you've got lots of findings that you can see. So most notably, you can see an area of neovascularization at the disc. Along the inferior arcade, there is some blocking. Um, I can't say for certain what that is, but there is a fluid level line. This suggests perhaps a pre-retinal hemorrhage, blocking the vasculature underneath. And you've got these also areas of capillary non-perfusion here and here along the inferior arcade, suggesting an ischemic eye. And these areas here of hot spots, again, suggesting either aneurysms or other areas of neovascularization elsewhere, for example, here. So putting these findings together, I've got an eye with a neovascularization at the disc, possibly a pre-retinal hemorrhage, some capillary non-perfusion, lots of microaneurysms. This is probably an ischemic eye, and in this case, this was a proliferative diabetic disease. So these are the sort of findings that an FFA can give you quite nicely, but it's important to remember that this area of blockage, while it's, in this context is probably a bleed, you need to be able to look at a color photo to know for certain where this is coming from. The other thing that you note with an FFA is this foveal avascular zone. So if I go back to some other pictures, what you can appreciate with an FFA is that you've got a very, very small area, even though there's pathology on these pictures, so it can be difficult to see. You have a very small area where you've got this no vessels at all at your fovea, and it's a foveal avascular zone, and that's normal. And in this case here, again, you've got this foveal avascular zone that's not particularly enlarged. But in this area here, you can see this foveal avascular zone is actually encroaching almost to half the size of a disc or even bigger, and that's much bigger than what you'd expect. And that suggests that this patient has some macular ischemia. And this is why a patient like this, I mean, you've got some potential ERMAs here, maybe some NVE, but this is someone who's perhaps a high risk, non-proliferative diabetic. But this area of macular ischemia will probably be contributing to slightly lower vision than you'd expect given the clinical exam of the patient. And that's an important thing to note. So in a talk that I've done previously, you can find it on the playlist for medical retina, where I've talked about diabetic eye disease. Macular ischemia is actually the main cause of severe vision loss in diabetes and not the actual retinopathy. It's the maculopathy that really makes a difference. And then, for example, you've got this a case with a CNV. You can see again this area of blockage, potentially a macular bleed, and then this area of leakage here, which over the course of the FFA you will note gets bigger and brighter, and that tells you that there's a neovascular membrane there leaking. Finally, I wanted to show you what a branch retinal vein occlusion will look like. Obviously, a CRVO will look very similar, but everywhere. This is a very acute BRVO. What you can see here is, again, this is a a collage picture of a patient's right eye, and along the supratemporal arcade, you've got these areas of blockage in a sort of flame shape. Again, when looking at a clinical picture, you can say whether or not these are bloods, but you don't know for certain until you've looked at it. You've got this feathering along the vessels again, areas of capillary non-perfusion, and this is all typical of a branched retinal vein occlusion. And with FFA findings, you can go and read this yourself. There are certain findings that put a branched retinal vein occlusion in a high risk category, and that specifically, for example, is having over 5 disc diameters worth of ischemia, disc area, sorry, and then with a central retinal vein occlusion, that's doubled to 10, and that gives you a highly ischemic eye, or an eye that is more likely to progress to have complications of a retinal vein occlusion. But you can go and read up on some of the other findings that you'll see on an FFA. The point of this talk is just to sort of show you some pictures of what things may look like or when you come across them either in clinical practice or in your exams. So in summary, we've spoken about the differences in your ICG and your FFA. We've spoken about the different indications, what the ICG is useful to see, what the FFA is useful to see, how to perform these tests, just in the terms of how it's actually done practically, the indications for them, and some important, that's what, sorry, that should say important consenting considerations to have, especially with an FFA. And we've also just touched on the common defects that you'll see, the hyperfluorescent patterns, the hypofluorescent patterns, and how to interpret FFAs with some of the common pathologies. So again, I really appreciate your feedback. There's a link in the description below. Please just click that. It will take you a couple of minutes to fill it out. And then that feedback can also then give you a link to then suggest some tutorial topics that you may want me to cover. So thanks for joining, and we'll see you at the next one.